So what's going to happen now? You're going above. Yeah. Someone said that. Yeah. Anti-clockwise move. So that is indicated in a gummy smile, decreased low anterior facial height, skeletal beat bite, horizontal growth pattern. See, the indications are easy to follow. Indications, even if you don't read this, you will know, because this is extruding, this is intruding. Where is it that you want it? Those are the indications. Nothing to, mug up this part. You have decreased low anterior facial height, that means you are going to extrude the posteriors. Now, cervical pull head here, forces passing below the center of resistance. So what moment are you going to get?
Clockwise.
Okay, good. You have understood now. I'm not worried. So the indications are the same. Skeletal open bite. Why? Because this is extruding, this is intruding. Skeletal open bite, vertical growth pattern, because this is intruding. Decreased incisor display, increased low anterior facial height. Okay, now let us, the outer bow, what will happen if the outer bow goes above the occlusal plane, at the occlusal plane, and below the occlusal plane? Let us just see. Now you can see you are traveling below the center of resistance. So it is a clockwise.
Clockwise with increased moment.
Now what is happening here also? Here it is above the occlusal plane, here it is at the occlusal plane, but the moment is the same. Okay? Moment is the same. Both you are passing below the center of resistance. No confusions here. Now again, you are traveling still below the occlusal plane. Above the occlusal plane, at the occlusal plane, below the occlusal plane, whatever said and done, you are traveling below the center of resistance. But what happens? What's the difference? Yes, look at the size of these arrows. So, it's all left to you. You want a greater change. You have a severe open bite situation. Then you can go for this. So everything is on the outer bow. Now let us look at this. Now what I am going to do here is I am altering the length of the outer bow. I am just altering the length. Here I am keeping it behind the center of resistance and above, and supposed to be above. Okay. So you are getting an anti-clockwise move. So I am just going to alter the length. Okay. The direction is going to be the same. So look at this. Length is altered. See the length? So here it is going above the center of resistance. Here it is going below the center of resistance. Same direction. I have only altered the length. But look at what is happening to the moment. Totally different. Here it is anti-clockwise, here it is clockwise. Now let us do something else. Here I am passing it below the occlusal plane. Here, what is the difference? Both are below the occlusal plane. I am only altering the length. This is longer, this is shorter. The moment remains the same. But look at the magnitude of the moment. So what I am trying to tell you is, it is not only the position of the outer bow. Going above, going below, going through the center of resistance is another story. That can change the moment. But at the same time, the length of the outer bow is also equally important. See, the whole moment itself changes here. Clockwise, anti-clockwise. And here, look at the magnitude of the moment. So this is a that place are one of the first inhabitants of Wayanad, that is in Kerala. Now let vertical pull headgear. Nothing much. It is only the design of the headgear which is different. And these are for elastics. You don't use power modules in this type of headgear. Okay, now if I have to go through the center of resistance, I will get a translatory movement. Now all of you know. And these are the indications: vertical maxillary excess, gummy spine, increased incisor display, increased low anterior facial height. That you can just understand by this movement itself, what are the indications. Now if I am going to go anterior to the center of resistance, I am going to get an anti-clockwise movement. And these are the indications: vertical maxillary excess, gummy smile, increased incisor display. And if I am going to go behind, posterior to the center of resistance, I will get a clockwise rotation. These are the indications. Skeletal open weight. Okay. Now, whenever you are using a headgear, you are having two forces. One is in the horizontal direction, moving posteriorly, and one is in the vertical direction. Okay. Now, this is where trigonometry comes. I'll put it very simple. I'm not going to get into too many things. Now, this is your headgear force, and this is your occlusal plane. Okay. Now, whenever you have a headgear, you have a horizontal component of force and you have a vertical component of force. Now, when I pass a force like this, I would like to know how much of force is going in the vertical, how much of force is going in the horizontal. Okay. So, I am not trying to tell you too many things. I have actually come with a lot of stuff, but this is your angle theta. So what you need to do, just like earlier, you take a lateral cephalogram with the headgear on. Okay? Then you draw this triangle. That is, you will have your headgear force going like this, and you will have your occlusal plane like this. Okay? You join these two, it becomes a triangle, and this angle is theta. Okay? Now, if you want to measure what is your horizontal force, then this is the formula, F cos theta. Now here, F is your force. Say you're putting about 300 grams of force. Okay? So F is your force, and theta is this angle here. So F, your force cos theta, will give you the horizontal component, and your vertical component is F sin theta. And let us see an example. Now let us say you're giving 300 grams of force. The force you know, you have to measure on the gauge how much of force, headgear force you are giving. Okay? That is 300 grams of force, and this is the angle, occlusal plane with the headgear power module, 10 degrees. So then F 300, that is the force, cos 10 degrees. So 295 grams is going in the horizontal, and F sin theta, 52 grams of force is going in the vertical. Similarly, even for your cervical pull headgear. Cervical pull headgear, this is your occlusal plane, and this is your force module direction, theta, and you will get your horizontal force and your vertical force. So accordingly, you can vary. So now if you want more of vertical force, then this vector should come more vertical. Accordingly, you alter your outer bow, make it short, make it long, however you want. So this vector, get it more vertical, your vertical forces will increase. You want less of vertical, you want more of horizontal, get the theta to reduce still further. Understood? So that way you can alter your horizontal component of force and your vertical component of force. So that was mainly the headgears being used, high pull and the cervical pull, for skeletal changes in growing children. Okay. Now it can be used for tooth movement also. It can be used for discalization especially. So it depends on how you want the occlusal plane. You want to tip the occlusal plane. This is an interlandi headgear. So now if you don't want any changes in the occlusal plane, keep your forces right on the occlusal plane. If you want the molar to be displaced, the center of rotation of the molar is at the furcation point. So you pass your force through, your outer board should be angulated such that it travels through the center of resistance of the molar. You will get bodily displacement of the molar. So however you want it, you get alter. That is for tooth movement. Then of course you can do small time cross-brace corrections by expanding the inner bow. Then you can control anchorage. You can ask the patient to wear the headgear during the nights. You will get a better anchorage. Then of course controlling the occlusal plane. They are again dental movements. If you want, even in an adult, you can close a bite or you can open a bite. The force magnitude is a big controversy. Now, as long as headgear therapy is concerned, all force magnitudes, varying time, everything is a controversy with different authors telling different values. Now, if you look at Jaday's textbook, he says for growth modulation you need 250 to 500 grams. For molar displacement you need 200 grams. For molar control, that is to hold the anchorage, you need 100 to 150 grams. Profit says 350 to 450 grams to move teeth. And then again, Markov. This is not only for tooth movement, most of it is for skeletal changes. Profit 350 to 450 is for skeletal changes. Markov again is for skeletal changes. So Markov says start with 200 per side, especially in the mixed dentition. You can go to up to 500 grams per side. That is 1000 grams both the sides. Urination again is a big controversy. You have Siatkowski saying that you need to wear it, you need not wear it for 24 hours, you can just wear it for 12 to 14 hours per night. Okay, this is for skeletal changes because he says there is more of growth during the night time. Why there is more of growth during the night time? Because there is growth hormone produced more in the night. So he says only 12 to 14 hours is sufficient. But if you look at Markov, he says 26 hours per day. It is just to impress upon you the importance of wearing the headgear. Markov says wear it as much as possible. That's why he says this is from this textbook and it is not a printing mistake. Okay, so and for if you want just for anchorage purpose, he says you can wear 18 to 20 hours. So my take on it is, if you are talking about force, I would say at least 500 to 600 grams of force per side is definitely required to want skeletal change. Second thing is, if you want faster changes, it is compulsory the patient should wear it 24 hours. You want headgears to work, the patient should wear it all the time. He should wear it to school. And everything is on your motivation, remember. You want a headgear patient to be successful, motivate nicely. Tell them it is just like wearing a mask during those COVID days. Get them to wear it 24 hours and the results are simply excellent. Now coming to the clinical management, how are you going to deliver a headgear? Okay? So the first thing is, you locate the center of resistance. Now, if it is the maxilla, let us take Prophet's center of resistance. It is between the two premolars. So what you do, you take a condenser, put it intraorally in the region between the two premolars, condenser, your conservative amalgam condenser. Take that instrument, put it intraorally, and then between the two premolars, point it out. Mark it with one marker. So similarly, if you want to move, you displace a molar, then mark the center of resistance of the molar on the outside of the face. Okay? Once you have done that, then place your headgear cap or your cervical neck strap. And then try to assess your zero moment line. Okay, you've already marked it on the face, and assess. And according to that, you will have to bend your outer bow. So I'll just give you a demonstration of how it is done. There's no volume. Can I get the volume? Can you adjust it here?
Choose a headgear strap that is as small as possible because we are doing headgears on growing children. And if you have a large headgear strap, then it will be too loose for the patient. This is the small size. You get small, medium and large size straps.
This is me, yeah?
These are the post modules. You need to open them this way and place them into the headgear strap and engage the post module. This is a spring-loaded device which gives you force. Similarly, you open the next module also, strap it on and fix the power module. Now your headgear strap is ready for delivery. This is the headgear splint. You can take a closer look. You have the inner bow to Adam's clamp and the outer bow.
Presently it is
Full
not
coverage
bent.
maxillary splint.
It is not bent out of bow.
When you deliver the splint, you must make sure that all the teeth are in contact with the splint. Here you can see that all the teeth are in equal contact with the splint. Now, mark the outer bow where you are going to give the bend. And roughly mark the center of resistance of the maxilla.
This is tortuous center of resistance. The posterior superior
This is the
part
orbit.
of the zygomaticomaxillary suture.
Palpate the lateral and inferior point of the orbit.
Posterior
Mark the
inferior
point
part of
just
the
below
orbit,
that
take a
on both
centimeter
sides.
away. That will be tortuous center of resistance.
According to Marco, this is
Not
the center of
Marco,
resistance of the maxilla. Use a heavy-duty 3-prong plier. Adapt the outer bow more closer to the face.
The outer bar should not be hanging out because it will get caught on the pillow and things like that. So adapt it more closer to the
Do it
face.
on both the sides.
And adjust these bends so that it will go through the center of resistance. If you want a translating movement of the maxilla, then make sure you pass it through the center of resistance. That's what I'm doing there now. Keep it close to the base, but not very close to the space.
Make sure you have both the arms in the same plane. Approximately around 400 to 500 grams of force can be given initially.
We go to even 600, 800 grams of force. The higher the force, always better, more the skeletal changes. I would say that how much ever the patient can tolerate, you give your force. Some patients will complain of pain in the head.
The headgear delivery hardly takes about 15 minutes.
You can see the center of resistance. It is how you motivate your patient. You must motivate your patient. Nothing is impossible. All the schools around our college premises, every small classroom will have at least 2 or 3 children having headgears. So this is, he has to connect this back. Thicker. So to bend it, it's not so easy. So coming to protraction headgear, try to finish fast. So I'll be talking about the classification, different types of protraction headgears, magnitude of force. Now, what is the rationale? Basically, the whole idea is to disassociate the maxilla from all the sutures, so that there is some amount of resorption and apposition that occurs at all the sutural surfaces. You have external and internal components. So the internal could be many things. The most common is a splint, especially in your mixed dentition. So McNamara says if you give a splint, it will prevent the eruption of teeth, so the lower anterior facial height will not increase. It could be cemented using a roofing cement, or it could be bonded with composite. So you etch the surface. Mostly it is in the mixed dentition, so you don't have to mind the etching. Etch the surface, put composite, pure it. Okay. This is mostly done in mixed dentition because you can't do a banding. Or if it is quite an adult patient, you want more of dental changes, you can go ahead with your fixed appliance. The only difference is you make sure that the hook is facing towards the distal. Or you can have an RME. There are a lot of authors who say that if you do an RME with protraction headgear, you will get better advance. You know, together we stand, divided we fall. So you divide, and then they say you will get better protraction also. But there are a lot of authors who say that even without protraction, without expansion also, you can get the same amount of protraction. Or you can even have it on a Cordelius also. Now, what are the different types? Deland face mask, which is basically a square framework. It has a forehead pad and a chin cap. And from your internal appliance, you will deliver your forces through elastics. Then you have the hip ham, not very popular. This is the chin cap. You have 2 short wires and 2 long wires. They go along the mandible and then end up behind the ear. And from here you can see it's flat, so you can't appreciate. This is the headgear strap.